So, welcome everyone. This is our fourth panel in our series. And today is the diagnostic day. So we have both two powerhouse of the diagnosticians in our panel with us. So one is pathology and one is radiology. So I would like to introduce you guys to them. So Grace and Chi, if you guys want to start by like introducing yourself, just a little bit of where you're from, what specialty you're going into, and like what institution you'll go into.
Yeah, I can start. Hi everyone. It's good to be back. I've been with F1 student doctor since day one of medical school, pretty much. So my name is Grace. I'm from China. I just graduated from Liberty University College of Osteopathic Medicine in Virginia. I will be starting first year. I'll be starting pathology residency program at Thomas Jefferson University Hospital in Philadelphia this July.
Awesome.
Hi, my name is Chi. Um, I'm originally from Vietnam. I go to Hopkins for medical school and I matched into combined diagnostic and interventional radiology at Harvard, Beth Israel, for residency.
Awesome. Welcome. Because my lab is at Israel. So we'll be within the same like institution slash like same location.
Nice.
Yeah, that'll be awesome. So I think we can get started with some thematic, just a moderated Q&A. And I think the first question, obviously, is to, since we have two of you guys here, can you guys tell us a little bit about your specialty, the type of residency you're going into, and what drew you to this residency, like this specialty? And I know, Grace, you have been on F1 Pod. We have talked about your journey a little bit, but I would love to for you to give us a little bit of like kind of story, like how did you come to deciding on pathology? Was it like, and also for both of you guys, is it during the rotation where you always wanted to, oh, we actually have audience. Give
Oh,
me
we have
one
all.
second.
That's cool. Oh, nice.
Yeah. So just like tell us a little bit about how you come to this residency of choice and what you love about it.
That's a loaded question, but sure. Sorry, I know Zach before. That's why I'm giving him a hard time. Okay, so I kind of wanted to go into pathology since day one of medical school. That was actually the whole reason why I decided to go to med school in the first place. But I understand that's not the case for majority of people who end up going to pathology. Unfortunately for pathology as a specialty, it is not very well exposed in during the 4 years of medical school. Yeah, there used to be a class, like curriculum designated to pathology, but now it's just been integrated into like all of the other disciplines, so to speak. So just kind of in short, my interest in pathology is more invested in forensic, which is figuring out the cause of death and working with the legal system and working with like the State Department, as well as law enforcement. So, but in order to get there, I need 4 years of pathology residency focusing on more clinical side of things, which is making diagnosis from biopsies, making decisions on blood transfusion, calling antibiotic resistance for infectious disease and kind of working alongside clinicians, giving them diagnostic information so that they could treat patients accordingly. And pathology to this day is still the gold standard of diagnosis. So because of my personality and my interest in research and just desire to figure out the why behind things, pathology was a specialty for me. And in terms of the matching process, it is it is kind of hidden. Like pathology as a specialty is kind of hidden behind the scene. That's why a lot of medical students don't even think about it, don't even realize that is a specialty that you could apply to, which in a sense makes it, less competitive in terms of, okay, there's not that many people applying, but also keep in mind there's not that many spots to begin with anyway. So like an average class size of incoming residents is about four. So it's pretty small class of residents that each institution takes every year. And also there's plenty of, it's a pretty IMG friendly specialty, I want to say. So like other than us graduating from the US, people graduate from India, from China, from Pakistan, like they all kind of want to use pathology as a backup, which is really not what you're supposed to be doing. So because of that, it's getting like secretively, like slowly becoming a little bit more competitive because of its nice, really nice work-life balance. You hardly have any calls. And a lot of things can be resolved remote, and your working hours is like 9 to 5. At least for, even doing residency training, like that's unthinkable, right? So those are some of the reasons I think why match is getting more difficult every year for pathology, even for US grads. Um, and then my reason coming to Jefferson, first of all, it's a very reputable institution. And, you see a variety of pathologies in Philly as a large city. And it has really great research resources as well as like city amenities like music and art. So, yeah, those are some of the reasons. It was my third choice, which I'm still very happy to end up with. So.
Yeah, I think Kevin will be really happy because he's currently at Thomas Jefferson. So hopefully when you guys get there, you
Yeah.
can get to connect a little bit. And yeah, what about you, Chi, in terms of radiology? How did you come to decide on going to radiology?
Yeah, so sorry for the background noise. My apartment's Wi-Fi decided to stop working this weekend. That's why I'm at a coffee shop right now.
Yeah, no worries.
Um, but so I would say that even though when most people think about radiology, they think about diagnostic radiology, um, which is like the bigger um, like like specialty, I would say. I'm actually going into interventional radiology. So
Mm,
interventional radiology is originally a fellowship
mm,
after a radiology residency, but nowadays they are integrated residency for both IR and DR, which is what I'm going into.
mm,
And it is about procedure as much as it is about diagnosis. And the reason why I wanted to go into IR, DRIR, is because one, I really like doing procedure. I know that I like between the internal medicine versus surgery kind of division. I know that I would be more of a surgery personality type because I wanted to do procedure with my hands and have very concrete problems that I solve and deliver that very concrete immediate result to patients. At the same time, I really like the imaging part of medicine. I think it is very diagnostic radiology. It's very intellectually stimulating, and it is like solving questions that is like very clinically pertinent to patient care without having to do all the social work part of internal medicine. So because of these, and also because I really like minimally invasive procedures. I think that is the future of medicine. More and more patients are like in general knowing about minimally invasive procedures, and it has a lot of benefit to patients compared to like open big surgery. And That's why I think IR is a really interesting specialty because it incorporates minimally invasive procedures. It incorporates a lot of the diagnostic aspect of diagnostic radiology, and also has a lot of technology and innovation going on, which is what I also wanted to pursue in my future career as well. So that's the reason why I decided to go into combined diagnostic and intervention radiology.
gotcha. And I think this bridged pretty well to my second question in terms of the structure of the residency you're going into. So I think for Grace and Chi, can you tell us a little bit of the overarching, like overall structure of your residency program? What are some of the division, like future directions that you can go into after you finish your general pathology or your interventional radiology residencies, and where are your passion lies, and what do you think imagining you're going into after you finish your residency?
Can I share screen? Oh, I
Yeah.
can? Okay.
Let me allow you to
Oh, okay.
share uh, all participants. Yep, now you can share.
Okay. Let's see if this works. All right. Yeah, so this is kind of funny. Uh, During my interview for Thomas Jefferson, the residency program director actually sent this to me as we were interviewing because I was asking questions about, like what you were saying about the structures of the residency. How do you progress from one level to the next? And I'm sure this is specific for pathology, but there are milestones like this for, I'm sure, every single residency program managed by ACGME.
Mhm.
So I think it's helpful, like even as an applicant, like in the fourth year medical student shoes, to be aware of these things so that when you ask questions during your interviews, you sound like you're informed, right? Like you know what you're kind of getting yourselves into. So I just kind of gave an example of pathology. Pathology residency combined APCP, anatomical clinical, is 4 year, 4 year long. And that's like the majority of pathology residency programs out there. So in those 4 years, you learn about, like how to diagnose surgical specimens coming out from surgery. You also have to know about, okay, how do you deal with like a blood transfusion reactions or any sort of, on the clinical side, meaning bodily fluid, surgical, anatomical side, meaning, parts. So that's, I think, the simplest way to break it up. And then from the 4 years, you're expected to progress, right? Just like in med school, from M1 to M4, your skills and your knowledge um, accumulates. And so then from level one, as you're just starting, I guess programs want you to identify key elements of a report, demonstrate understanding of timely reporting, basically saying, okay, something's wrong with this. Like this doesn't look normal. Let me find somebody. And then as you progress through second year and third year, your responsibility increases and there's more expected of you. I think it's really helpful in the way that like the programs also like most resident, at least for pathology residency program is set up in the way that you have recurrent rotations. So I was like, for example, if I'm rotating through breast, for first block during first year, I'm seeing breast like one time, and then when third year comes around, I'm back rotating in breast pathology or so then the expectation on me will be different compared to when I was there during first year. Although it's the same kind of rotation, but because my responsibilities are different, therefore it's going to look different, right? Schedule wise and like what is my workload, etc. And then
Mhm.
eventually, like going on to level four, like you're actually pretty much functioning at this point like a junior attending is some of the pathologists told me like nobody ever reaches level five. And even if your attending said you're level five, they're just being nice. So yeah, it's and kind of like I just nobody expects you to know everything from the very beginning, especially for pathology. It's not like because you don't really get exposed to pathology. Like there's no way I am getting so many pathology rotation during med school that I'm functioning as a
Mhm.
PGY2 at the time of starting. Some people are like that because there's fellowship, like pathology post-sophomore fellowship program. Essentially, they take a year off of medical school and do pathology during that year. So it is possible, but extremely rare.
Mhm.
So I just kind of want to point that out in terms of general program structure and then aligning that with the ACGME guideline.
Mhm.
And as you're like for med students, as you're looking through exploring programs and formulating like, okay, like how are the schedules? What do I look for? Does this make sense? Use this as a guideline and then asked during your interviews of questions along like these lines that would, you know, make you sound really intelligent. Like you really know what you're talking about. So yeah, that's just kind of something I wanted to point out that I thought was really useful very early on. And
Mhm.
then like there are many like aspects as well. So like I'm sure this is more relevant as to like clinical specialties. Okay, what is the expectation, because ultimately you have to pass boards, right? Your specialty boards, and like these organizations come and inspect your programs to make sure they're aligning themselves with the requirement of ACGME. So
Gotcha.
yeah.
And for when you're applying to residency programs in pathology, do you have to go through APCP together, or is it something that's you can cater what you're interested in? If you're more, I know some of my friends who are very interested in more the molecular side, they're more into the CP side or the heme CP particular. Is that something you can choose when you are applying to residencies?
So some, I've said like majority programs, they only offer APCP combined.
Mhm.
Some programs, like larger program, Cleveland Clinic, for example, they have AP only or CP only. So like you were saying, your friend was really interested in molecular, if there's really no point unless he's trying to practice in the community setting for him to do surgical or anatomical pathology. So he could just do CP, which is 3 year only. So AP only or CP only is only 3 years. And then if you do APCP combined, it's 4 years. So for majority pathologists who want to keep their options open and be more marketable when it comes to finding a real job, majority of them would opt for APCP, because what if, somehow your friend decides, oh, I'm not sure about molecular. I think I'd rather do transfusion, or I'd rather, like do search path. That seems really cool. It's like he would need that AP portion for his board certification. Yeah.
Gotcha. And what about you, Chi? I know that you're talking about the division, the synergy between interventional and diagnostic. Can you tell us a little bit of, how is your residency structured, and what are some of the possible future directions you can go into?
Yeah, so I can talk a little bit about both diagnostic and interventional radiology residency. So, diagnostic radiology residency is so part of the reason why I can talk about both is because many people who applied into IR actually do will apply into DR and IR. So I did also look into both DR and IR residencies. So for diagnostic radiology, it is a 5 years residency, and the first year or intern year will be either in internal medicine or transition or a transitional year, and the 4 years, the later 4 years will be in diagnostic radiology. And after a 5 years, and almost all diagnostic radiology residency are advanced, which means you have to complete like a separate intern year in IM or transitional year elsewhere. And after a 5 years diagnostic radiology residency, all fellowships are 1 year in length. So you can specialize in chest, in neuroradiology, in MSK, in breast, body imaging, and so on. And so, in general, someone who wants to be very specialized in DR will complete say 6 years total of training, 5 residency, and 1 fellowship. It is so I don't know if it's very commonly known right now, but the job market for radiology in general is very, very hot. Right now, there's a very big shortage of radiologists, so it is very easy to have job offer even without a fellowship. Um, Currently, however, especially if you only want to work in a community practice setting. However, if you want to pursue an academic position, you need to do a fellowship at this point. So as I mentioned before, interventional radiology used to be a fellowship after DR, and there's still an option right now to follow that path in which you complete 5 years of DR and then 2 years of IR. So IR is the only fellowship that is 2 years long, just because of how much skills you need to gain in your fellowship in IR.
Gotcha.
However, most people who wanted to go into IR nowadays would choose to go the integrated pathway, in which you have 1 year, 1 intern year, and many IR program requires a surgical intern year. And I personally also will do a surgical intern year. The next 3 years is are basically identical to a DR residency. You basically do all of the rotations that a diagnostic radiology residents do, except some programs will have a longer like components in their DR years. And then the last 2 years are IR focused. You complete mostly IR rotations, and finish up like a few last DR requirements during your last 2 years. So that's the 6 years integrated IR residency. And there's no IR itself is already very specialized niche field, so there's no ACGME fellowship after IR, but you can do like you can do neuro IR, which mean which mean you do all of the I don't know angiogram in the brain. So that is actually something that's shared with neurosurgery. People can go to interventional neuroradiology through neurosurgery residency, through neurology's residency, and some programs also accept IR residency, but not every fellowship accept IR. You can also do but again, not a lot of IR people decided to go into interventional neuro IR. Is a very small number, but it is an option out there. And again, another small number of people may choose to do some fellowship in pediatric IR, but you don't need to be fellowship trained to do pediatric IR. It is just an option, a couple of months that some people want to be hyper specialized and work in a very academic setting may choose to do.
I see. So, I guess, can you tell us a little bit? I think for people who just started med school, and I think it's still pretty interesting in terms of what interventional radiology does in terms of you know, what type of pathologies you guys treat. Can you tell us a little bit of what's the bread and butter cases in interventional radiology?
Yes. So the three kind of main components of interventional radiology is first imaging, second minimally invasive procedure, and third patient care, pre-op and post-op. And IR does all procedures that involve the blood vessels, all minimally invasive image guided procedures involving the blood vessels in the entire body, except for the brain and the heart. The brain procedures is done by interventional neuroradiology, which again is in fellowship that some IR people may decide to do, and the heart procedure is are performed by interventional cardiology. But outside of those two organs, everything else is done by IR. So some examples of arterial interventions that IR does is trauma embolization. So when someone has a trauma and is bleeding in the spleen or bleeding in the liver after a motor vehicle accident, for example, they can have they can either have a surgical or IR or interventional radiology embolization, depending on like their acuity and like the other like clinical factors. And what IR does is to go into the blood vessel, most commonly in the spleen in a trauma patient that is bleeding, and deliver some beads that occlude the artery and stop the bleeding. So that is arterial procedure. IR also does venous procedure. So for example, someone is with a pulmonary embolism. There are surgical treatment option and also interventional radiology treatment option depending on the grade of your embolism. And what IR can do is a thrombectomy, which means like going to the pulmonary like going into the pulmonary vein and basically suck out the blood clot. IR can also do men's health and women's health procedure like uterine artery embolization to treat uterine fibroids or post delivery hemorrhage. Like in the past, when patients have like, a lot of hemorrhage after a delivery. Like sometimes hysterectomy is the only option, but nowadays a lot of patients may undergo embolization of the uterine artery, so they can keep their uterus and basically the blood vessels that's bleeding is blocked off you like temporarily in a couple of weeks or like maybe permanently using a super glue kind of. That's really quick. Same for men's health. So benign prostate hyperplasia can be treated. Many patients nowadays choose to treat their BPH with a procedure called prostate artery embolization, where the arteries that supply the prostate is blocked off with some beads, so that like the prostate will kind of shrink and get smaller. Other than that, there's also interventional oncology, mainly treating solid tumor of the liver and of the kidney. Some of these is using the also a catheter to block off the arteries that supply the liver tumor, and some of this is also using microwave ablation or cryoablation, so using a needle under CT imaging guidance, basically burn off using heat or kind of freeze a tumor, usually kidney or liver tumor. There are also GI procedures like putting G tube in for patients for nutrition, like other GGU procedure like suprapubic catheter placement. So yeah, also some MSK procedure as well. Like you may know about some a new treatment for osteoarthritis, which is genicular artery embolization, basically block off arteries that supply the inflamed joint to treat osteoarthritis. So there's a very wide range of procedures that IR can do using minimally invasive. All of these are minimally invasive using image guided, and patients usually leave the hospital within the same day or on the next day and have really good recovery from all of these procedures.
Yeah, that's awesome. Thank you for, educating us on interventional radiology. And I think, hi Kevin. Thank you for joining us. And I think we can transition a little bit into kind of what we're very interested in understanding is the administrative side, where all of us as international students who are pursuing residency in the US will have to obtain visas. And just in terms of logistics, can you tell us a little bit of what are some of the challenges you have faced, and how did you come to decide which route to go, whether it's H-1B or J-1, and some of the considerations you have had during the application season?
I can go. Then I'm gonna go drink some water. So so on freda.org, and there's also, what is this app called? Like a Residency Explorer. I think that's the official AMC one. There's like search criteria. You can check like for visa sponsorship. And I think there's total of maybe like 60 to 100 programs, pathology residency programs in the US. And then once you limit like your search to like H-1B visa sponsorship only, it only ends up being like 20 to 30, which makes my application process easier so that I don't have to apply to all 60, right? And then within those 20 to 30, based on my geographical like preferences and like, program structures, even just looking at, okay, like the past, cohorts of residents, do they look like you, first of all, right? Like, do they only take MDs or are they all IMGs? Like, are you going to fit in there? So I think there are a lot of just very not even not even thinking about, okay, like what kind of like program, what kind of resources they have, but simply just trying to get a sense of the culture. Because I think what a lot of us don't realize is that you're not going to single-handedly change the culture of your program. Like it's already established, is what it is, right? So like you're the one trying to fit in to the program culture. And I think that's also the consideration of the residency program directors and the selection committee, right?
Mhm.
It's like, oh, is this candidate going to fit well with us, or versus is this the best candidate in the entire world that we can get for our program, right? Because it's not like you're not trying to compare yourself against others on a straight scale, right? There's so many other factors considered. So then for me, I literally just only almost exclusively applied to the programs that offered H-1B. At first, I really wanted to return to the Midwest because I graduated undergrad there. I wanted, I like enjoy the Midwest culture for some reasons. So I applied to a lot of Midwest programs, and Thomas Jefferson's actually the only one on the East Coast and ended up here. So that's a different story. And then in addition to that, because I'm pursuing like I'm hoping to do forensic pathology fellowship afterwards.
Mhm.
So another consideration for those who are going to fellowships or want to pursue further trainings after residency is to look in the program, see where people end up, right, after the residency training,
Mhm.
or whether there are good rotation opportunities for your future fellowship in the geographical location or like, even within the residency program that you're looking at, right? Like, do you have opportunities to rotate at the medical examiner's office or at a children's hospital or at a very specific, like, comprehensive hematological cancer center for hemopath? So like those are also consideration, just kind of thinking little further down the line beyond your residency training time period. And then, next tier down, I'm sure like people have family, they have other considerations as well, right? In terms of schools, resources for families, etc. Like for the spouse, are they able to find a job?
Mhm.
But for international students, I would say like visa consideration is probably the most important thing. Like I have also spoken to a lot of my IMG colleagues, like they graduated from another country. So coming here, like they literally face a lot more hardships than us, I feel like, than us who graduated from the US. So like as long as the program offers you H-1B, which does not require the 2-year home residency, you're pretty much good, because that is on the green card track for employment sponsorship or EB1 or EB2. So that's probably the most important criteria for our specific situations. So
Mhm. Yeah. Thank you, Grace. And what about you? What about you, G?
Yeah. So I think when I was looking for programs to apply to visa sponsorship is also the most important factor. I basically so I wanted only the H-1B visa to begin with. However, when I was deciding on what programs to apply to, um, I was really intimidated by how competitive IR and DR is. On average, an average applicant apply to like usually between 60 to 100 DR residency programs, all IR residency programs. So anywhere between 60 to 100 is very common. And I know residents who match at Hopkins for IR. A resident told me that she applied to basically all IR programs out there, so 100 and something. So that is the extreme that some people went in order to match into IR or DR. So when I was looking for a program to apply to, I was I decided that I will apply to both programs that offer H1B and programs that offer J1 visas. So in total, I think we applied to like 50-ish programs, and that I think I already excluded several programs that offer only J1 and are at like geographical location that I really don't want to be. So I applied to all H1B programs and a couple of J1 programs that are at like like ideal geographical location.
Mhm.
And I use the residency explorer kind of function also within the My ERAS portal. So the same thing that Grace used. However, I would say that these data are not updated. So after I applied and after I interviewed to a lot of programs, a resident I know who is also a so she also went to Hopkins for medical school on F1 visa, and she's currently a resident on H1B visa. She told me that I really need to email each program coordinator to confirm the type of visa that a program offers, because sometimes the data on the official website is outdated, and and you don't know how fast things change, especially this year. So I did, and lo and behold, 3 days before rank list was due, I learned that many of my top choice programs said on their website that, like on the portal that they offer both H1B and J1, ended up saying that, oh, they only offer J1 visa. And this came to me as a very big surprise, because these include some of the very, very big academic institutions that you would assume probably offer all type of like visas out there. So, and I think what I learned from this is that the visa policy varied from institution, but also within different departments
Mhm.
in the same institution. Because there are institutions who I know offer, just last year, offer H1B visa for residents in other specialties, in other departments. But for my particular department, which is radiology, they may not offer it. It's just a departmental decision sometimes, especially um, especially when I think there's also a financial factor, because um, the money that is used for H1B application, like there's a fee, and the fee is usually coming from the department. So maybe the one explanation that I was given is that maybe the institution, there are some institutions that like flat out tells you from the beginning that their entire institution only offer J1, but there are institutions that allow both J1 H1B, but the decision of whether an H1B visa is an option kind of depend on the funding of the department and depending on the year. So it really changes year by year and department by department. So it's always safe to email the program coordinator before you. I think it's a little bit too much to email before you even send an application, but definitely either ask during your interview day, and if you don't feel comfortable asking during your interview day, email the program coordinators of programs that you interview before you make your rank list and submit your rank list.
Gotcha. Yeah, I was gonna ask about like both of you guys' opinion on the timing. Let's say you submit the application. Obviously, don't ask them a question before you even submit. What about like, there's kind of the three time period between you submit your application to when you receive your interview on your interview day, but also after your interview, but before you make a rank list. What do you think is like your opinion? Like, what's the best time to ask in terms of like what are the policy? Because things can change, and I also know that there are like department that's like a case by case base that I don't know what it means. It can be really subjective. Like, am I good enough for H1B versus J1? That's also somewhat interesting thing. But yeah, to both of you, what do you think is the best timing in terms of asking about this sensitive topic?
Yeah. I mean, well, first of all, like it's not sensitive in the sense that you shouldn't ask or it's looked down upon if you ask like, oh, okay, it's like, like, should we even rank her if she's only seeking for this one visa type? I mean, it is a very practical consideration, right? For our, for everybody in our shoes. So I would say like, don't be afraid to ask. Like you're not bothering them. Like this is a legitimate question, right? Like this determines the next 4 years of my life. So I need to know. But in terms of timeline, I feel like it's gonna vary quite a bit based on what specialty you applied to, and then how the way the schedule each specialty or each program follows to roll out interviews. So for pathologists, pathology at residency this year, I think they had a uniform release date or some sort. It's like October 26th. So supposedly all the programs participating in this uniform release timeline should not be sending out interview invites prior to October 26th. But that being said, some programs who opted out of the program or the unified release date, they started sending out literally like last week of September or like beginning of no October. I actually received the one from Thomas Jefferson like first week of October. So that was like the first interview invite I received, which is, like I only submitted my application like a couple weeks ago. They reviewed, they have a very fast turnaround time. So I feel like that would determine, okay, once like for people like Chi and all who apply to like 50, 60 plus programs, you need to figure out how many are you reasonably going to attend, right? You probably won't be able to attend all 50, 60 of them. So then that comes the question, okay, how many of these programs am I going to email and ask visa related questions? Or should I wait till after the interview? For me personally, um, I tried to look for as much information as I can on their website, and like she was saying, like 100%, like all the time, they don't update their information, so they're not accurate, and they may change policy literally during your application cycle. Maybe they had the previous policy like last year, like that last physical year that was in effect all the way up to when you start to interview or when you start your onboarding for residency. So who knows? But in terms of for what I waited till after I interviewed with the program, and sometimes it's nice because like sometimes the residency program director or the current residents who are interviewing, they are pretty knowledgeable. Like some of them have, required visa, so they can just answer your question like on the spot when you have the resident Q&A, or like during your specific interview, they'll ask you, do you have any additional questions? If they don't know the answer, they will say, oh, I'll find that out for you. I'll make sure to email you like afterwards, so that way you initiated the conversation during their interview, so they know like you need this information and we'll get it to you. But if that doesn't come across during the interview, like I've always just to put things in writing so that they know who I am, like who's asking this, and they can pass it along to usually the residency program director wouldn't know everything because that's not what they're paid to do. They would forward the email to like the HR, like GME, HR, who is in charge of like all the visas and working with the legal team, etc., and to make sure everyone has the documents required to go on July 1st. So they will forward, like for two of the programs, they forwarded my email to the HR, and I got a response from the HR with like very detailed information, like a timeline in terms of, okay, when would we apply for the H-1B for you? And then we would require you to pass step 3 by this month or something, and then you would start your residency in OPT, or along those lines. So like they're pretty, I would say transparent for the most part. When you ask the questions directly, right? Because they're not offended. Like we need this information, and we need the information to make an informed decision. So I think they're pretty good with it. So that's kind of my timeline in terms of like between interviewing and submitting rank order list. I was pretty lucky because my interviews pretty much ended by the end of, November. So I had like plenty of time to like sort all that out. But again, it's gonna vary, depends on when your interviews end and when you do like rank list submission by like February 10th or something. So my rank lists have just been kind of sitting there. I don't really change because there's so many things I feel like factor into where you end up matching. It's not just, oh, this is my preference, therefore hopefully it goes that way. But what I did, just like I finished ranking and just give the rest to the Lord. And he'll place me where, he sees fit. So yeah.
I have a question. I don't know if I'm jumping the themes a little bit, but just like kind of like sorry for jumping the questions. It sounds like both of you guys like the application like strategy was sort of like a shotgun approach, like applying to as many and like as broad as possible, like pretty much to all the programs that sponsor H-1B and like everywhere geographically that's like in your preference. But in terms of like actually approaching like sort of like the competitiveness of a application, or like trying to gauge like which schools are sort of like reaching, which schools are kind of like target schools versus like safety, like sort of below your tier. Um, like what is your approach? Like how do you do this sort of like self-evaluation? Or was there someone from the school or from somewhere else to kind of guide you through the process?
I can go. I can answer both that question and the previous question. Um, so again, about when to ask about visa. I I think I want to share something that will save a lot of people a lot of time, because I definitely had go through every single website and scrutinize every single kind of fine prints about these kind of visa eligibility matters, which took so long, which took so much time that I feel like I wanted to share it so that people don't have to do so. But maybe some people will still want to do it if they are paranoid like me. So when people say by case, mainly there's two divisions between H1B and J1. Usually, a lot of the time, if you graduate from medical school outside of the US, most of the time you are only eligible for J1 visa, or like institution will only give you J1 visa. The only kind of exception for H1B visa is usually people who are international, who are like foreign citizen but attend medical school in the US. There are definitely institutions that give H1B even to ING who attend medical school outside the US as well. But in general, you hold an MD degree from a US institution, you have a better chance of getting an H1B. And this is where, again, email and ask institutions about their particular policy for a particular year is very helpful, because sometimes institutions may say that they only offer J1 visa, but actually they do make exception for people who own MD, and that is actually true for Johns Hopkins, because on on almost all official websites they say that they only offer J1 visa, but I know for a fact that they give H1B visa for definitely for people who attend Hopkins for medical school, because I know residents who were medical student at Hopkins and who are currently resident at Hopkins, and they got the H1B visa. So from talking to them, I know that Hopkins does this, but they don't share it publicly in a lot of places, including on the My Era Residency Explorer portal. So again, sometimes it's very helpful to just email the program coordinator, especially if it is a program that you really like. And if you hold an MD from a medical school in the US, sometimes it's helpful to just email and ask the program coordinator directly, because sometimes they do make exception for US MD graduate. And about when to ask about this, I think it really depends on the specialty that you go into. I know a friend of mine who is going into internal medicine. Asked immediately during his interview for IM residency whether they just confirm that a program offer H1B and J1 visa. For me, um, I was a little bit of a paranoid person. I was afraid that if I talk too much about visa, that may people may rank me lower. So I didn't ask until after, and I didn't ask the director. I just asked the program coordinator. Thinking back, I don't think it is. I I feel like there are pros and cons. Like you probably wanted to be very open, and you want to go to somewhere that is very supportive of people needing visa. You don't want to have to hide who you are and what you need in order to succeed during the residency. So I think it's also okay. It's probably also okay to ask um, during your interview. I think before your interview, I don't think it makes sense, because you may not be offered an interview at a place anyway. So unless you are tight on finance and wanted to decide where to apply to based on that information, then yes, you can ask before interview. But I think either during your interview or after interview is a good time. I know people who are from like a little bit more competitive specialties. Like I know someone who is an international student and going into ophthalmology. Also wait until like after the interview and to ask about this. And it is also true for me who is going into radiology. But maybe for someone who is going into internal medicine and which is more friendly to international citizen, it's probably okay to ask during your interview about where to apply and how to gauge your competitiveness. I think your mentor at your school is the best resource for you, especially someone who has know you well in medical school. However, I will say that like this like for me, I have mentor who knows me really well within the Department of Interventional Radiology at Hopkins. So I just went to him and went to these people and give them basically. I think it also depends on how comfortable you are with your mentor as well. Because one of my mentors is actually the PD at Hopkins. So do I really want to tell the PD of one of the program I'm applying to, like where else I'm applying to and what I'm thinking? But I think it's actually to my best interest to have them look in through my list. So I have my attending look at my application list, so the programs that I'm applying to, the program that I'm signaling, and also the program that I'm ranking. I would say though, these people know very well about your competitiveness for your specialty, but they don't know anything about visa. Like absolutely not. So they are not aware that some programs will just not take me because I need a visa. So and actually, I think for medical school, no one really will know how visa affect your competitiveness other than you do. Like there is no kind of advisor, international student advisor at medical school, just because of how few medical students are there at medical school in the US. So I would say that make your list based like kind of make your initial list based on the visa and then give that list with all the programs that you know already offer the visa you need to a mentor in your field, and they will decide your competitiveness within that list, but don't count on them on any information regarding visa because they know absolutely nothing about that.
Yeah, I would second that as well. It it's we're in a pretty tricky situation. And I feel like, on the one hand, there's so many people like out there trying to help you in your medical school, but they don't really know your full story, right? Like all the things that you have to consider. But I would just say like get advice from a variety of people. And then, like sit down and like consider, okay, what do you do with all of this information? And in terms of applying to programs, I definitely like in terms of seeing like, okay, how competitive you are on Residency Explorer, there's some information on like the average like USMLE scores for incoming residents, like those who applied and those who got in, like successfully matched with that program. So I think that's if you need numbers, right? If you need something like, quantifiable, that's a good place to start, right? Or like number of like publications, number of like leadership, whatever, volunteer experiences, etc. So like if you kind of use that as a reference, not necessarily to say there are people above and below that. It's just average, right? But I think that's also helpful in saying, hey, oh, like if all of these people are, what top 95 percentiles USMLE score in step two, like if we're not there, then maybe not. Maybe that's not the program for you. Or like for me, because I graduated from a DO school, right? So like since the residency whatever application system combined, the ERAS is it one ERAS one whatever, right? For both DOs and MDs. Some programs, like majority of programs are very receptible to taking both DOs and MD candidates. But unfortunately, majority some of like really old school programs, they are very much MD exclusive almost. If you look on their website, like meet our residents, for the past 3 to 4 years, they've only had MD PhDs or MDs, then maybe maybe that's not the place for you. It's not saying it's impossible. It's not impossible for a DO to get matched there, but like the question is, are you gonna fit, right? Like, like, are you gonna have the best experience there, with the existing program makeup? So I think that's another consideration as well.
Thank you so much for your answers. So it's almost at the end of our panels for time. So I guess the final question for both of you would be something like if you were looking back to this whole process is was there anything you will say to yourself like back a couple months ago, like anything that you feel like you should know earlier or anything you would do different looking back? Or it can be like any sort of last minute tips for our mentees who might be applying upcoming years.
I would say that for me, um, definitely emailing the program coordinator as opposed to relying just on the official data or like kind of published data. I personally emailed the program coordinator for all programs that I interviewed at, but I did so pretty late, and that added a lot of stress to my rank list. I felt like I should have done it a little bit earlier because, again, and I think it's very, very necessary, or at least for my specialty, uh, because programs may change, and many programs, in my experience, change a policy from what they published online. So, email program coordinators about visa sponsorship is kind of a at least like a couple weeks before rank list is due to kind of to be best informed while you are making the rank list. I think it's like very important advice, and like something that I wish I have done earlier this year. Yeah.
So since the experience was fairly recent, a lot like I'm also personally just trying to like reconcile myself. So like for me personally, I would say, I wish I had been more open-minded, so to speak. Like, because I almost had the like the fixation on the Midwest. It's like I was so desperate to go back to the Midwest. I don't even know why. I'm like, it doesn't make any sense. Like, your residency really is a time of your professional journey to be exposed to a variety of things, and you want diversity. You want, like varied experiences, and that is probably best done, at least for pathology, I think, in like large city settings versus rural settings. I mean, it's great. Like you can always go back to rural settings to practice later on after your training. But I think during residency is you want more exposure. You just want like a lot of exposure to like, rare diseases and like rare diagnoses that you probably won't be able to see anywhere else. So like larger institutions and larger places are definitely better for that purpose. So part of me just thinks that, oh, I would be so happy if I could go back to the Midwest, and also at the same time, they're not that competitive. So I thought that was, my top choice was definitely in the bag, but did not turn out that way. And looking back, I feel like, oh, thank you. Thank you, Kevin. And looking back, I realized that probably was the best thing that happened, during the math process, despite not getting my first choice. Like my third choice, TJU, is actually the best training place for me personally, like given my passion for research and interest in arts and all my hobbies, and just like a good place to grow further, if that makes sense. Like if I go back to Midwest, I'd be very comfortable, right? Because I already know the environment, I already know the people, know the program. I can just relax for the next 4 years. But that's not the way it's supposed to be, right? We're still very young, we're just starting our career. We shouldn't just be trying to, sit back and relax and like take the easy route. So I think at the end of the day, I realized I think the whole match algorithm, like nobody knows how it works still. But I feel like for residency programs, they are not just trying to get you to where you want to go, but they are trying to get you to where the places that's best for you, right? Best for your growth, like professionally speaking, how to make you the best pathologist, best radiologist. That's actually from one of my interview with Dr. Tang, like my residency program director. That's literally what she said. It's like, oh, I'm sure you all succeed in residency programs. You all pass the exams. She has no doubt of it. But the point of the match process to get you to was the best place for your training. So that just, that really resonated with me. And like at the end of it all, looking back, it made sense. So I would just suggest to everybody, like, just keep an open mind. You might not end up with your first choice for the place you thought was best for you, but you never know, right? What life may bring. So you might really enjoy your training at the place where you matched. So.
Thank you so much. I know TGU is probably not a top choice, but I'm super happy. Welcome to Philadelphia. And I'm sure like Jefferson got one of the best residents they can ever get. And she, congratulations to you too. I know you're coming to Boston, so Zach's probably waiting for you to meet up in person. So it's such a nice coincidence. But thank you guys so much for sharing our experiences. And congratulations on our match too. Zach, do you have anything else you want to add on?
No, I just want to, echo what you have said. Thank you for your time and always willing to contribute and help the community. And, this interview is recorded. We'll put them up to our YouTube, or we can even post them on the podcast, whatever, route that we decide to do. This will be a really valuable resources for international students who are interested in both pathology and radiology. So thank you so much, and wish you the best of luck in residency.
Thank
Thank
you
you.
both.
Bye.
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 Stop recording.